Hello, this is Chapter 4, Substance Misuse with a Co-Occurring Mental Disorder or Disability. In this chapter, you will learn a little bit about what integrative treatment is, working with those who have intellectual developmental disabilities, those who have physical disabilities, and people with co-occurring disorders. We'll talk a little bit about which types of mental health disorders tend to have an issue with addiction more so than other mental health disorders and different things like that as well. So the first part that we are going to cover or address is talking a little bit about co-occurring disorders. The authors refer to having mental illness and addiction issues as a double whammy of troubles that worsens each condition. I used to say, what came first? That theory, what came first, the chicken or the egg? So I used to reference what came first, your drug and alcohol issues or your mental health issues, because both may be equally, as troublesome or equally as important to address, but which one of them came first? Was it your drug and alcohol issues that then, because of your chemical imbalance in your brain, caused you to have mental health issues? Or were you using substances to cover up your mental health issues? So sometimes we don't know which one came first. Sometimes maybe there wasn't a prevailing issue, I should say, that, caused one or the other. Or maybe now you just have struggled with both. Really, any of the above could be a possible scenario. Both do go hand in hand, and it is hard to tell which may have came first for a person, and having both can worsen one or the other. The book later tells us that 36% of adults with a substance use disorder have a behavioral health diagnosis. So that's quite a large percentage of people that struggle with both mental health and drug and alcohol, which would make it a co-occurring disorder. Due to separate funding sources, so mental health has its own funding source and drug and alcohol has its own funding source. They have been trying to treat mental health and drug and alcohol as two separate issues. So the question becomes, does that work? Is it better to treat one separate or treat them together? Evidence shows that traditional separate treatment for mental health and addiction issues is ineffective. So if you're only treating one part of the problem, you're not really solving a problem, is what what research is saying. Thus comes in the practice of integrated treatment. So integrated treatment is taking a look at both your mental health and your drug and alcohol and putting them together. So you're working on both issues at the same time, is integrative treatment. Or they could be treated simultaneously. Maybe not necessarily in the same treatment session, but maybe you're going to drug and alcohol treatment, which is still separate, and mental health treatment, which is still separate, but you're doing both at the same time. A lot of times that's what you're going to see more so than maybe doing both within the same treatment session for, the reason mentioned above is different separate funding sources. But you may touch upon issues in both treatments. Very confusing. So why has this historically been such a difficult treatment issue? And why is treatment so ineffective? I mean, the success rate is less than 5%, and there are high dropout rates. So some of those reasons to answer that question would be providers act like the person is just one thing at a time. So when you call and you do your initial intake, or I should say intake, but like your screening questions over the phone, or maybe you do your initial intake when you first come into the facility, they're going to see which issue seems to be worse than the other issue. So they're going to screen you for drug and alcohol, or they're going to screen you for mental health, both type things, just to see which one are you, which one are they diagnosing you. We mentioned different funding streams for each at national, state, and local levels. Typical for providers to identify one disorder as primary and the other as secondary. So mental health might be primary and the drug abuse might be secondary, or vice versa. Battles over which disorder might be primary is also an issue too. For example, if a person has a bipolar problem and they're treated for bipolar and that goes away, then the addiction will go away as well, or the opposite, depending on what type of provider you are. So maybe if you treat the drug and alcohol issue, the bipolar issue goes away. However, we know that with bipolar, that's not the case. Another reason for this is they're, busy protecting program boundaries, but the client and or patient is not at the center. So a lot of times we see this parallel or sequential treatment, but it's not integrated treatment. And there's different battles over treatment methods. We have that issue too. So, we've talked before that there's not one treatment that helps everybody. So maybe people with bipolar disorder might need or might respond better to one type of treatment, but those who struggle with heroin addiction may respond better to a different type of treatment. So there's different treatment methods, and it's a battle of which one is going to work for this person with this co-occurring disorder. And if there is a behavioral health issue and drinking, they can refuse treatment for behavioral health, and if they're not abstinent, and at a substance abuse program because they have a behavioral health disorder. So a person could come in who may be struggling with a behavioral health disorder as well as a substance abuse disorder, and they may refuse one of the treatments to make whatever one they want to be primary. So that's an issue that could happen as well. So what often happens to people who don't get combined treatment? They end up going to the emergency room as one place. Over 10% of emergency room visits by adults are due to either substance use or behavioral health problems. Or they may end up in the criminal justice system. Jails and prisons are more likely to break the law, are more likely to have people with both behavioral health and substance use disorders because they're more likely to break the law or violate probation and parole. Or they don't have the supports that they need to stay out of jail. So we're having overpopulated prisons and jails. Half of all prison and jail inmates have a behavioral health diagnosis. And of these, 70% have a co-occurring substance abuse disorder. So obviously that statistic is very high, that crime is likely to be associated with people who have co-occurring disorders. 70%, that's a pretty large number. So different reforms were implemented in the mid-1980s. By 2004, 35% of the facilities surveyed in a national survey of substance abuse treatment services had special programs or groups for clients with co-occurring psychiatric and substance abuse disorders. In 2014, which was only a few years ago, among the 7.9 million adults with co-occurring mental disorders and substance abuse disorders, 54% received no treatment at all, 34% only treatment for mental health problems, 3.5% received only specialty substance use treatment, and 8.9% received both treatment for mental health and specialty substance use treatment. So that is a pretty skewed ratio here. We have 54% who didn't get any treatment, 34 who only got treatment for their mental health. But what about the substance abuse treatment? Those percentages are fairly low. If 3.5 just specifically had their substance use treatment, and only 8.9 got both treatments. So, are we emphasizing this integrative treatment or not? The Mental Health Parity and Addiction Equity Act of 2008 ended discrimination in insurance coverage. Categories variously named dual diagnosis, coexisting disorders, and persons with mental illness and chemical abuse or addiction, or persons with chemical abuse and mental illness are now referred to as co-occurring disorders to indicate the presence of both substance abuse or dependence and serious mental disorders. Moving on with that, substance misuse and mental disorders, the largest study shows that people with serious behavioral health problems such as schizophrenia, bipolar, or major depression diagnoses are 4 to 5 times higher than individuals without these diagnoses to use drugs. So why is that number so high? NIDA indicates that drug use impacts many of the same brain circuits that are disrupted in severe mental disorders such as schizophrenia. Some of the most common mental health issues found with substance use problems are typically your bipolar, your generalized anxiety disorder, PTSD, schizophrenia, schizoaffective, major depression, personality disorders, and pathological gambling. And some of the substances that are typically misused with these are alcohol, tobacco, cannabis, and cocaine. That kind of ranks in order too, alcohol being number 1 on the list. Reasons for using these appear to be the same. So we have loneliness, anxiety, boredom, and insomnia. And these findings contradict the popular notion that people with mental illness use substances to self-medicate their symptoms or side effects of medication. So they're saying that whether you have whether you do have a co-occurring disorder or whether you just straight use substances, you're using for the same reasons: the loneliness, anxiety, boredom, etc. Dually diagnosed persons tend to be more vulnerable, so they're more susceptible. They're more likely to experience frequent hospitalizations, relapse, depression, suicide, stuff like that, or financial issues too. Differential diagnosis means giving a diagnosis that is accurate, that differentiates the truth from other hunches. So I believe that diagnosis can be difficult because, when you initially give a diagnosis to a person, you may only be spending a short amount of time with them, but sometimes a diagnosis can develop over a longer period of time. And sometimes it's not cookie cutter either. What may look like one type of diagnosis may be also kind of shared with a different diagnosis as well. So there's no one specific answer. Sometimes they're cookie cutter type diagnosis for a person. The authors look at diagnosing as a complex decision. So, they're not seeing it as a very easy answer either. So I would definitely agree with your textbook on that. So what is most important is to continuously evaluate symptoms, especially the relationship with substance use, because, again, if you have a person with a co-occurring disorder and the symptoms that you may see that person experiencing could be from the substances too. So if you remove the substances, then you're going to get a completely different outlook, or you may have a different diagnosis. So what the ideal situation would be is to continue, assessing the person's symptoms throughout treatment, and that may change their diagnosis. So what should assessment look like? Finding out what stage of change a person is in and how much insight the person has about the harms and benefits of their use. Finding out the details of their use, so what type of drug are they using, what's the frequency that they're using, the amount, the patterns, etc. Find out the details of medications that they're on, or attempts to control with other medications. Past treatment experiences. Is there any religious or cultural affiliations that you need to be aware of? Those are, things that you should assess to kind of help a person with a co-occurring disorder in treatment. So the next part of this lecture video that we're going to cover is disorders that commonly co-occur with substance use. So, we mentioned a few of them before, such as bipolar, schizophrenia, anxiety. We're going to talk a little bit about each of those disorders and how they are more likely to use substances. Let's start with anxiety. Types of disorders that would fall under the anxiety category might be panic attacks, agoraphobia, phobias, obsessive compulsive disorders, post-traumatic stress disorders, and general types of anxiety disorders. Anxiety is probably the most common disorder for those with alcohol or drug users. 25% of alcohol-dependent people and 40% of drug-dependent people struggle with anxiety. If you suffer from anxiety, your chances of having an alcohol use disorder is 2 to 3 times higher, and a drug disorder is 6 times higher if you struggle with it. And of course, too, keep in mind that addiction itself is anxiety producing too. Some drugs have anxiety as an effect. So stimulants, marijuana, hallucinogens may have anxiety as a side effect or an effect of the drug use, or an effect of the withdrawal too. Most clear up in 2 to 4 weeks after withdrawal. So if a person has anxiety that is related to drug use, it's going to kind of subside in 2 to 4 weeks. However, if symptoms continue after 30 days of abstinence, the person should be assessed for an independent anxiety disorder, so something that stands aside from the actual drug use. There may be bigger issues. Everyone with anxiety problems in your practice or hospital should be screened for substance abuse problems using a simple screen. And we do talk about some of these screening procedures in Chapter 7. Under this category too, we have post-traumatic stress disorder. So this is, your vets coming home from war, different, other people maybe have experienced a very traumatic situation, maybe something like a rape or an accident of some sort too, can also suffer from post-traumatic stress disorder. So what that is re-experiencing a traumatic event over and over again. Some of the symptoms that a person with post-traumatic stress disorder may have may be intrusive thoughts, flashbacks. They may avoid certain places, certain people, different triggers. They have a lot of fear, guilt, self-blame. a lot of self-destructive behaviors, and they might be hypervigilant. 30% of women and 8% of men have post-traumatic stress disorder symptoms after severe trauma, and a lesser percent after moderate trauma. There's different ways that you could treat PTSD with different types of medications that may be helpful as well. But this is a common one that people are going to use substances with, is this post-traumatic stress disorder. Next, we have bipolar disorders and depressive disorders. The depressive disorders used to be called mood disorders in the previous DSM-4, not DSM-5. So these are highs or lows in your mood, and they're considered to be pathological. Depression, major depression, and persistent depressive disorder is less severe but longer acting than major depression. Bipolar disorders, you're going to have episodes of mania and depression. There was a prison study, 90% of those with a bipolar disorder also had a substance-related problem. And this is associated with bipolar, or drugs that are associated with bipolar is cocaine and alcohol. All right. Along with anxiety, these are the second most common diagnosis. So bipolar disorder or depressive disorder for people with alcohol or drug disorders. Alcohol and drugs can cause these symptoms as well, and so can withdrawal. So a person may be having the symptoms that reflect or resemble bipolar or depressive disorder, but maybe they're just going through withdrawal, as we mentioned with anxiety as well. So usually there's a window. If you're still having these symptoms after that window, then there might be more reason to believe that it is actually a bipolar diagnosis or a depressive disorder diagnosis. Personality disorders. Rigid patterns of deeply ingrained behaviors and thoughts that are pervasive and can cause personal distress. Borderline, dependent, and antisocial are some. Narcissistic, passive-aggressive, obsessive-compulsive personality disorder, which is a little bit different than obsessive-compulsive disorder itself, and can be culturally determined, however. These are prevalent with people with substance use disorders. So 34 to 78% of people struggle with these. Schizophrenia. I'm not sure if you've heard of schizophrenia disorder, and there's a different range of, you have your schizoaffective disorder, schizophrenia. There's different versions of this as well that are in the DSM-5. And there's also, lumped in with schizophrenia is other psychotic disorders as well. Specifically related to schizophrenia, most commonly diagnosed of this category of disorders, you're going to have abnormal social behavior, failure to understand what is real. So you may think something is real, but it is not real. Common symptoms include false beliefs, unclear or confused thinking. You might hear voices, see things, reduced social engagement and emotional expression, and a lack of motivation. People with schizophrenia often have additional mental health problems such as anxiety, major depressive illness, or substance use disorder. Paranoid schizophrenia is a subtype in the delusions that they are being attacked. So they're constantly worried about something coming to get them, whether it be aliens or the government or anything like that. There always is that fear or paranoia that someone's out to get them. People with schizophrenia can be very high functioning. There was a movie a couple years back, A Beautiful Mind. John Nash was a Nobel Prize winning economist. Symptoms for schizophrenia tend to come on gradually, and you might see signs of these in young adulthood and then kind of gradually come on over time. The onset is anywhere from ages 16 to 30, and the symptoms will stick around. About 50% of people with schizophrenia have substance abuse at some point, compared with 17% in the general population. Schizoaffective disorder is a little bit different. So it's schizophrenia plus having a mood disorder. Again, the onset is in early childhood. The manic type has symptoms of mania, hypomania, or mixed episodes. Depressive type, you're going to have depression. Common symptoms of this disorder include hallucinations, paranoia, delusions, and disorganized speech and thinking. So obviously very similar to schizophrenia. However, you're adding like that mood component with it too. Delusional disorder is the last one we're going to talk about in this category. The patient presents with delusions, but with no accompanying prominent hallucinations, thought disorder, mood disorder, or significant flattening of affect. Delusions are a specific symptom of psychosis. Delusions can be bizarre or non-bizarre in content. Non-bizarre delusions are fixed false beliefs that involve situations that could potentially occur in real life. Some examples might include being followed or being poisoned. They could be fixated on that, and those are things that could happen in real life. Apart from their delusions, people with delusional disorder may continue to socialize and function in a normal manner, and their behavior does not generally seem odd or bizarre. However, the preoccupation with delusional ideas can be disruptive to their overall lives. These people can be high functioning, and for the diagnosis to be made, auditory and visual hallucinations cannot be prominent. So they could still be having hallucinations, but it may not be like the prominent thing that they're having. All right, so we're going to move on to the quadrant model. There are 4 variations of co-occurring disorders to select different types of treatment settings. So there was 4 quadrants that you may have remembered seeing in your textbook. So the first quadrant is low on both, and those could be treated. So you have low mental health and low on the substance use scale. So those could be treated just with your primary health care type options. The second quadrant is high mental health and low substance use. So behavioral health treatment with substance abuse input, or maybe integrative treatment. So they're going to focus just on your behavioral health treatment, mental health treatment, not so much the substance abuse. So it may come up in conversation, but that's not the sole focus. The third quadrant that your book talks about is high substance abuse and low mental health. So it's going to be the opposite. You're going to be primarily focused on substance abuse treatment. It might touch upon a few behavioral health or mental health issues, but it's not going to be a separate treatment. It might be integrated. And the fourth quadrant is high on both. So you got severe mental health and severe drug and alcohol. So that quadrant group of people is really the ones who need that integrative treatment. So you're treating both at the same time. So that is the quadrant model that your textbook talks about a little bit about as well. So we are going to stop there for this part of the lecture video, and we will continue on talking about, integrative treatment in the second part of this lecture video. So please stay tuned and we'll keep going. Thank you.